I want us to be challenging the way we're thinking. It's what our patients deserve. If you're not challenging what you've been taught for the last 10 years in training or however long it is now, if you're not really challenging what you've been taught, then you're probably not doing it right, in my opinion. I mean, you've been taught some amazing things. The question is, how do you get it? How do you hone it right? How do you get it to working for your patients? None of that happens by staying stagnant. And none of the improvements that our patients deserve moving forward are going to come from that line of thinking.
Welcome back to the Spine Pod. I'm Courtney Schutze. I'm here with my co-host Brady Riesgraf, and we are in Prosser, Washington, and we sat down with Dr. David Yam.
This is such a fun episode. Very rarely do we get to sit down with someone that is so highly recommended, and we've had so many people recommend Dr. Yam, and you can see why. I mean, the continuum of care and the care that he provides to such a breadth of patients, he does a little bit of everything, and I think he has such a unique perspective because he's been doing this for so long and he's worked with so many different devices, so many different technologies, and truly everything that he does is aimed at how do I improve patient care?
I am so excited for this episode for our entire audience, especially patients, because he does such a great job breaking down and giving advice for patients on when is it the right time to get care, which often he says it's don't get surgery, right? He's trying to avoid that for you, to when you want something and insurance is a hurdle, how do you work through that? There's so many good nuggets in this episode. And what I really love about him the most is his life philosophy of if it's hard, if it's a challenge, I'm going to lean in. And in this space, we need more people like Dr. Yam. And I'm so excited we got to share him with our audience.
Well, and he's willing and does put up the fight that needs to be fought, right? And he's doing that for patients. He's doing that for other surgeons. He's doing that for the healthcare system as a whole, right? And so I think it's really exciting and it's palpable when you're around that, right? You can feel the energy, you can feel the passion, and truly every single thing that he does is aimed at that one exact thing, is how do we provide better patient care? And that comes through a variety of different systems, right? How we treat them and how long he can sit in the room with patients and what technologies he's using and how he helps shape their care continuum, right? But it's so much fun because we know so many different surgeons that one, he's been mentored by, right? But also kind of this group of surgeons that he has around him that are also fighting this fight and truly, truly pushing to just provide the highest level of care possible. And I think it's really fun to be around.
I agree. We've been really lucky that we've got to sit in rooms with a lot of surgeons, a lot of spine surgeons, a lot of different types of surgeons, and just, clinicians and providers in general. And you can typically get a sense of if they just talk the talk or if they walk the walk. And Dr. David Yam, he does both. And it is so clear that his heart is really in the right place. And he is about getting medicine back to what medicine is about. And he does such a great job explaining that in this episode.
And he literally talks about it of wanting to make an impact, right? And everything he does on a day-to-day basis is exactly for that one thing. And you can see he's done it with patients, he's done it with the practices that he's touched, and he does it because now he is a mentor to a lot of the people underneath him, right? The surgeons and the professionals. So it's a lot of fun to sit down with him, to get to know him and be able to spend this time. I think we're really, really grateful and we're excited to be able to share his story.
I agree. And he's got some really good movie references too, which is a lot of fun. But I think we let him get into it.
Let's jump in.
Enjoy this episode with Dr. David Yam.
Dr. David Yam, thank you for joining us today.
Yeah, thanks for having me. It's a great opportunity to talk with you guys. I really appreciate you having me on. It's the other way around.
we both have been stalking you on LinkedIn for quite some time. So we have been so excited to come out here and do an episode with you.
I've heard really good things about you. Started following your podcast as well. So I'm like I said, the dialogue I hope we can get going here is going to be amazing, I think, and hopefully I can deliver what you guys are expecting. So
Oh, we know you will. We're so excited.
We certainly will. Well, this is gorgeous. We're sitting at a brand new hospital here, Prosser Memorial in Prosser, Washington, and this is stunning. I mean, like, this is gorgeous. We came in and we're like, oh, this is the hospital out here. This is amazing. This is really beautiful. I know you started out here 8 months ago or so, in the last year here, and this is really beautiful. But for the people that are sitting down, we're sitting down with, an expert in minimally invasive surgery and motion preservation, a neurosurgeon yourself who's been practicing for 20 years now and has all that experience. And truly what Courtney just talked about is you have a LinkedIn following and have created a LinkedIn following, 6,000 followers almost on LinkedIn. And it's because of a lot of the education and the work that you do. And that's why we've been so excited to sit down with you. So we're excited to jump into some of those things today. Some of the fun parts for us is talking about how this all originated and what got you into surgery. You grew up in Tennessee. What was that like growing up in Tennessee?
It was interesting. I love Tennessee. In fact, I'm wearing my Tennessee pin today just to honor it a little bit and remind me of my my past, because it's important where you come from.
Absolutely.
And there's some really good people that I owe a lot to that are still there. And I grew up in Knoxville. My dad is actually Chinese and my mom was Caucasian, so that was a little unusual for the time. But created a world that I got to see two very different perspectives on how the world works, and grew up kind of in that environment, and had an older brother who's literally my best friend to this day, and a younger brother who's 6 years younger, so a little bit of a gap, but he's still a very good friend. And very, very big impacts on my life in terms of how I think, and I think how I do things, and they're big parts of my life still.
And your dad actually immigrated here from China when he was 18, right? I mean,
Correct.
That's a crazy story itself.
Yeah, he was an orphan in China and just got a college offer to come to the United States and go to a small college in Kentucky, and he didn't really have any money to even call his own. And he came over to this country, and when he checked in and they asked him what his name was, he said Ren, and they wrote down Yam.
No way.
Yeah,
that's how you ended up with your last name.
That's my long history of the legacy of the Yam family.
Wow.
It was written down wrong.
So you're second generation. That's great.
Very long history of a dynasty, in fact, of
The
Yams.
Yam dynasty.
Yeah.
What was the draw to medicine? Because you went to school in UT right there in Knoxville, but what was the draw did you know when you were in undergrad that you were doing medicine and going that route?
Not really. I mean, my mom was a physical therapist. So kind of growing up, I had a lot of interactions with patients because she would take us to work. That's just, instead of childcare. I mean, we weren't wealthy. We grew up with small means, and so I'd go to work in the summertime with her and hang out, and my older brother did too, my younger brother did too, and we got a lot of interactions with patients through that. So that's, I think, kind of the start of it. And then as I was going through school, I think probably the best way to describe my high school years is like football, hanging out with friends, dating. Hacky sack maybe is a relatively big one.
Way back.
Yeah.
Oh my gosh, hacky sack days.
It's kind of crazy. I didn't really care about school that much. And then in my senior year in high school, I went to a hospital and toured the ORs and walking around, and I'm watching an open heart surgery. It's amazing. Watching a bunch of these kind of crazy procedures going on just as an outsider, obviously. And then I see an orthopedic surgery happening, and they're doing a total knee, and I passed out.
Did you?
Which was kind of crazy. But what that taught me is there's obviously something about that bothered me. And I think most of my life, I've always kind of liked a good challenge. And so the next year I'm in college, I want to be back in that environment. I want to be able to succeed where I feel like I failed. I mean, I'm just a student, so nobody had any real expectations of me, but I had an expectation of myself, and maybe I didn't realize that until that happened. And so that's kind of where I went back. I was an orderly for um, several years, just helping, getting exposed to that environment more and more and more. And I think, between my mom being an inspiration for me with patients and then me wanting to always do something that's challenging, that was the most challenging thing I think I'd ever had, is like not being able to stand and hold myself up even. It was such a shock to me. So
That's pretty incredible that I think most people would be like, this means it's not for me. And that you leaned in is like, it's a testament to who you are. That's really cool.
I totally agree. I was going to say the same thing. I've heard so many of those stories the exact opposite direction,
Yeah.
especially like on the rep or clinical specialist side of like, oh, this sounds like a great thing.
Yeah.
I love sales, or I love being, and then they see blood and they're out and they're like, oh, this isn't for me. What was it for you where you said, no, I'm going to lean into this thing versus backing away and saying, there's something else made for me, right? Because that'd be a very easy thing to say, is there's
yeah,
a
I mean,
different path
I
for
think
me.
definitely the thought crossed my mind. It was sort of that idea that, I could just do anything, right? Do anything but, right?
Mm.
But like I said earlier, I like a good challenge. In fact, probably the worst thing to do if you if you're going up against me, or you have something, a competition or whatever, tell me I can't win. Tell me I can't do it. Tell me it's not possible. That's actually, I think I thrive on it. I might sort of be like Marty McFly from Back to the Future. I do a lot of movie references, if you can't tell. But I might be that guy, like, like he calls him Chicken, and then all of a sudden it's just like, no, I gotta prove this. I gotta do this, even if it's hard, challenging, difficult. I want to succeed. There's not anything I think is really truly impossible.
What a great trait to have for as a surgeon,
In
right?
medicine,
And someone that's trying to, which is exactly what you're doing, trying to change the dynamic and how we provide care and to provide better care too. Is that the same leap that got you into neurosurgery then? So medicine, and then you pretty much take on as one of the most challenging aspects.
Yeah, so I really didn't think I was going to be a neurosurgeon. In fact, like I thought I was going to be an interventional radiologist for a long time, and so I was leaning that way. Most people who want to be neurosurgeons, they're like, oh, I've wanted to be a neurosurgeon since I was like, had a pacifier, or like maybe kindergarten or something. But starting out as like a third year med student and deciding you want to be a neurosurgeon, that's kind of crazy. But I rotated through neurosurgery, and after kind of thinking all this stuff through, and I'm like, I don't want to be a surgeon. It's too many hours, too difficult. But then that drive still inside me is just like, no, I rotated for a week on neurosurgery, and I was just like, I have to do this. It's so challenging. This is such an interesting field. You learn anatomy from brain to toes because we do nerve surgery everywhere. And I was like, there's very few surgeons that can do that. Like, I mean, there's amazing work that a heart surgeon does, and general surgeon work, and all this stuff that people do. But I think at the fundamental level, it's like understanding neurophysiology, understanding neuroanatomy, and then trying to repair that. It just like same energy that I was talking about earlier. Is like, that's a challenge. That's something I can really like put a career into. And I tell my son who's going into engineering, he's like, he looks at me, he's like, I don't want to do your job. He's 17, he's a senior in high school. He's like, I don't like what your hours are. I don't like, that you get called all the time. And, that's kind of his thing. But for me, it was the opposite. Just, I want to do more and be involved in more stuff.
So my background way back when I was on the med school track was neurobiology, and that's what I did. And I always found it fascinating that we can go to space, we've gone to the moon, we really are still trying to understand how synapses work in the brain, right?
Yeah.
And like neuronal, it's absolutely amazing to me. So I love that side of, I'm just looking for a challenge, right?
Yeah.
And trying to improve it. So, and you stayed in Tennessee for all of your training. Did
That's
you know
correct.
you were going to do, because you went from Knoxville and then you went over to Memphis for, internship and residency in med school?
Yeah, so when I decided third year I wanted to do this, my best friend going through med school was one of these like neurosurgeons for life guys. And, I'm joining the club like the last minute. He's like, wait, now you're my competitor. And Jody Helms, he's a great guy. He, we're both sort of like, looking around like we kind of want this spot, we want these spots. They're not going to take both of us. And I wanted to stay in Tennessee because of my experiences there. One of my actually key mentors is Kevin Foley, who is like the godfather of modern spine surgery. I mean, literally tubes and a lot of the stuff that we do today is based on his kind of preliminary ideas and work. And so I saw him there, and I just was like, I really want to stay in Memphis. I could have gone anywhere. I was the top of my class, even though I wasn't really, trying that hard. But I wanted to stay there, and he wanted to stay there. And then by some miracle, we both matched there, and we got to spend the next 6 years working together
That's great.
with really one of my really good med school friends. So
It's a testament to you that not working that hard puts you at the top of your class.
Goodness
That's not a normal
gracious
thing.
for neurosurgery.
yeah, I don't know what happened. Like something happened. I started caring about stuff. The hacky sack kid turned into the guy that really wanted to put himself out there and work hard. Like I said, I kind of look back to that whole experience. Like I wanted to do something challenging. So I think it's been a driver.
And did you find it challenging once you got in it?
Oh, absolutely. I mean, there's the hours are crazy, the work is crazy. It's very stressful. We lose a lot more patients in neurosurgery probably than almost any other specialty, which is hard, and nobody teaches you how to deal with that. Um, it's not you lose them during elective stuff. It's always traumas and really tragic brain tumors and stuff, and it's hard. It's hard. I think that's one of the hardest parts about it, and that's probably why I do spine now. It's because the outcomes are better, even if the outcomes are not perfect. They're my patients are still walking around and talking and doing the things that I want them to do. So that's probably why I'm a little niched out of that. But the reality is yeah, that was hard doing
Mhm.
that, learning, and I had great mentors though. That's one of the things is like even on the toughest days, I had really good leaders, friends, co-residents, and recently graduated attendings that were really good people that really helped drive things. And just like anything else, you can also learn like really bad stuff from really bad people. But you can take that experience and say like I'm never doing it that way, and it's equally helpful actually, and to learn what not to do
Mhm.
sometimes.
Well, to your point, you brought up Dr. Kevin Foley.
Yeah.
Has kind of created the Mary. We've been spent a lot of time at Memphis doing
Yeah.
research and development, all those sort of things. Can you talk about what it was like working with him and the other folks that you did? Because we always talk about mentorship and how big of a role that plays and kind of the trajectory of truthfully your career sitting underneath that. And he is, one of the most well known that the spine community knows.
Yeah, he definitely started the Mary. I started teaching at the Mary as a PGY2.
No way.
So yeah, Medtronic or some of these other companies would call up and say, "Hey, our surgeon that was supposed to come in and teach this course today did not show up, and um, could you have anybody you can loan us for the day?" And
No
so
way.
sometimes that was me, and I'm like a year into neurosurgery, and I'm supposed to teach how to do an MIST lift to somebody that is 20 years into practice, and I start doing these courses, and I keep running into this guy that is also shows up in the Mary periodically. You might know him. It's Dr. Scott Hodges. Uh,
Know him a little bit.
and he's very entertaining. So I've known him for forever, and he kind of took me. He realized like, wait, this guy's pretty fresh.
He caught on, huh?
He's like, yeah, he sort of knows what he's doing, but he's pretty young, He's like, I don't know what I was like 25 at the time, so that was a long time ago, and but yeah, that's where I met Scott, and I sort of took me under his wing even that early, that long ago, and like we ended up doing a ton of courses over many years, and at the Mary, and so that's kind of where I met him. And then with working with Foley was an amazing experience. Just He does mostly MIS, which is what I do now. So I kind of copied him. I did my first lumbar artificial disc with him because he was in the IDE study, and I did my first cervical disc replacement with him, which he's in the IDE study for that. And so, my foundations in minimally invasive and motion preservation really stem from a lot that I learned from Foley.
It's incredible. The Mary Lab's such a great place.
Yeah.
Mhm.
I can't imagine. I mean, probably 100 cadaver labs at least over there and training and their staff and everything. But you and Dr. Hodges for sure share the wanting to be educators and getting the word out there, because that's something that he believes in very strongly as well, is kind of passing the torch and being able to teach some of those things, just like Foley does, right?
Yeah.
It's such a big component of bringing up the next wave of surgeons.
Yeah, and I absolutely love teaching. I was at OHSU for a while. That's a fundamental thing I miss about that experience was, you know, just interacting with young surgeons that are really trying to learn stuff, and they don't know what they don't know, and I don't know everything either. But the reality is like, it was really fun to do that, and so for decades I've been teaching other surgeons how to do procedures. It is one of the funnest things to do, to meet people, engage with them, see how their mind works, see how their learning skills. Like that's a different skill that I've had to
Mhm.
learn. That's what I think Scott realized that I didn't know how to do any of that stuff. Um, but it's an acquired skill. It's a challenge. I'm an introvert by nature, so I don't like any of this. But I don't mind it at all. I mean, I enjoy it now actually. So it's like I said, I go for the challenge. If I feel a little pressure in here, it's probably a good thing.
Yeah,
Love
absolutely. Well,
that.
yourself and Dr. Hodges and Dr. Foley, the spine community is very fortunate for that, right? The Mary Lab and just all the teaching and education.
Yeah.
You touched on a component because you were over in Memphis, you were in UT, and you talk about very, very good mentors. You're also the other side of the spectrum, and there's the bad side of medicine. You were in school with Dr. Death. Can you talk about what that was like?
Yeah. So um, Chris Dunch was a year ahead of me. So he was technically my chief for the entire time, upper level resident ahead of me, the entire time I was there, with the exception of my actual last chief
Mm.
year. And yeah, I mean, I think when I first met him, the first time I met him, I was a med student, and he was, kind of rotating around. And at that point, I would do anything to do surgery, like brain surgery, doesn't matter what it is. I wanted to scrub in every case I could. I was trying to soak this stuff up. It's what I wanted to do. And this guy was very different. Like he would just come over and say, "Hey, you want to come do this case for me? I got some other stuff I want to do." And it was very different. Like I just was like, "This is strange, right? This person's not like most of us were all there for the same reason. Like learn this stuff, hone it, learn how to do it better." And he was very different. Like he just didn't want to, you know, show up to rounds. He didn't want to show up and do patient care. Didn't want to come and do surgeries. I mean, this is crazy to most of us over there, and most of us don't talk about it. So it's it's a tricky question. But as he's going through, that's kind of the style that he had. He just was very hands off about the things that I think are most important to forming you as a surgeon. And some of that was just the overconfidence that I think he had. Um, you know, um, I don't think he thought he needed to learn these things, but I mean, like I said, this is one of the most challenging things you can do, and there's so much you can do wrong.
Mhm.
And definitely, that's what his track record showed when he got out.
Probably the most public event, I would say, like in the spine, neuro and ortho spine community of anywhere. And obviously it's been, belabored to all ends with documentaries and everything like that. But it is crazy to think that that can or did happen at
Happen.
some point, right?
Yeah,
And when you look over it, right, on the continuum of everything, there's bad actors that slip through the cracks in anything, in like any area, right?
yeah.
But you just have this assumption, as a patient or in the industry, that once you go through that amount of training, like there's a vetting process that kind of weeds out the bad. And obviously we learned on the backside that it just, wasn't handled through all that. But that's a crazy experience.
It is. And, I think, one of Chris's failings is that he's a drug abuser, in my opinion. I kind of saw that firsthand going through residency. I mean, I didn't hang out with him and do anything, but the reality is it's
You
like,
can tell if somebody
I mean, you
is,
can
yeah.
tell. And, just like Hollywood, just like anything else, if you use the wrong substance for the wrong amount of time, it catches up with you.
Mhm.
I mean, that's a tragic way so many uh, actors pass away, how producers pass away, how we lose some of the most talented people in that industry to the same process. And I actually think in Chris's situation, I know he's got problems, but I'm not defending anything that he did. But at the same time, um, his, I think it's more a testament of like the failures of the system, like more than anything else. Like if somebody's saying something and doing something, the best thing isn't to just hide and keep it quiet and pass it along. I mean that's the key opportunity to either change that person's life. Sometimes it's a hard thing to do. Like
Mhm.
somebody needs to come tell you that you're not where you're supposed to be. You're not doing what you're supposed to be doing, and you need to fix it and put you through a process that fixes it. Otherwise, that's his story plays out. And I
Mhm.
think it's a story more about the big system than it is at the end of the day about Chris.
I think that's a really good point. I think, and it's hard because spine surgery kind of gets a bad rap to begin with. And
Yeah.
then you have this story that kind of just breaks that open in such a way.
Yeah, it's a lot to repair.
It's a lot to repair, and it makes patients scared. I'm from the Dallas Fort Worth area. So
Yeah.
like when the podcast first came out, which it was several years ago
Yeah.
now, but I remember listening to it and just being like, that's
Yeah,
scary to think
that's
it's,
my neck of the woods.
yeah,
Yeah.
just right here. And for patients to not understand, if you're not in the space, like how could that even happen? Who do I trust then? Do you have any perspective there to kind of like bring this around to say, like he did fall through the cracks. It wasn't it was a problem with him, but it was also our system not being built up. But this isn't a common thing. There's a reason that there's this one story that's been told, but I think it can be a scary thing, especially when it's dramatized in a
Mm.
podcast and in a show. Just your perspective there.
If you're a patient, you should, talk to the surgeon. You should question. I mean, it doesn't matter if it's a neurosurgeon or a urologist or whoever. You should be questioning what they're telling you. You should research things, not just Yelp reviews. Really research things as best you can. Try to understand their rationale, and then whenever you can, get a second opinion.
Mhm.
I mean, I tell patients all the time, especially with increasing complexity of things, like just go get another opinion. I'll even give you good names of people that I would trust to operate on me,
Mhm.
to see. And I know that can add time to the process, but if you need that, do that. Like, I feel like it's smart to tell patients that, and it's smart to encourage that, get people really thinking about their health, um, not just, talking with you one time and then making some life-changing decision if you can avoid it. I mean, if you have a good interaction with the person, that's great, but do some research on the back end too as best you can. Um, and like I said, whenever you can, get that second opinion about things, because there's a lot of ways you can do spine surgery.
Mhm.
I definitely do my own style, and a lot of people have great techniques, and that's their style. And some of their techniques work better for certain things, and I acknowledge that. And as patients, you need to understand that. Like, the surgeon you're seeing may have a special resource or a special skill set, and they might be one of the best in the world at it, but there may be something different about your situation, and you need to have questions ready, and you really think about things if you have the time to do that.
I think it's such a good point. We're talking a little bit, we're getting into, which is the reason that we want to sit down with you, is your care philosophy, right? Which I think is so important. You're you talk about your mentors, but you're an educator and you're a mentor yourself, right? To all these other folks out there. I pulled one of the lines that you had talked about on LinkedIn, and essentially your key tagline was, most cases of back pain will resolve themselves without ever needing to see a surgeon. That's someone who's essentially saying, the thing that I get paid to do, we can solve a lot of your problems without that. For you, you had all this mentorship and education. Where did that philosophy come from? Was that from the patients that we were seeing? Was that from people you were training with? Where did that come from and develop? Because there's a wide spectrum of how, surgeons and just practitioners in general look at patient care.
I think that comes from a lot of places, a lot of mentorship. But really, truthfully, I think one thing that hit home to me is like 1 year into my actual practice, finishing residency, I'm moving a big, heavy patient, and I herniated a disc, like literally while I turned them at the start of the surgery. So that's not a good time to have your
No, not
leg
ideal.
on fire. Uh, and then yeah, so that's kind of eye opener. But so I didn't really know what nerve pain was until I had some. Um, and then I know the literature, the data really suggests that you're going to get better without surgery. I need to go through this now. And I'm not going to show you my back today, but the reality is I don't have a back incision. I'm a firm believer in non-operative care. It works more often than I think people are willing to understand and or appreciate. And the reality is, yeah. So I that's a big part of my practice is actually talking people out of doing major surgeries whenever I can. Now, some things you have to fix, and some things are better fixed. And there's actually really good data about a lot of what we do that says like this care actually works better than that care. But at the same time, if it's only been like a week of symptoms or even a month, maybe it's great to just try to beat it. I don't want to really have surgery. I don't know that anyone really wants to have back surgery. Maybe when they're like in duress and you're sort of sweating, and I'm thinking back to like I'm moving this patient, now I'm doing her surgery with right leg pain. I'm thinking about that. But, in the moment I was like, yeah, maybe I'll have back surgery, but that passed pretty quickly for me because I'm like, I think I'll wait.
Yeah.
But a lot of my mentors showed that. It's just like you can operate on every person that comes in with acute symptoms or even chronic symptoms. But you can also not operate on most of those people. Have a conversation with them, get things going, have them work through the process of that care, and the ones that fail, you treat, and the ones that you don't operate on, you might see them later
Hmm.
because the problem gets worse or changes, and that's fine. I'd rather operate at the right time and maximize their quality of life. That's sometimes early, that's sometimes really late.
That's what I was going to ask you. Have you found that there's kind of a sweet spot of when to treat? Because I think there's a wide spectrum. Like if you talk to patients, people can say, I've been hurting for a couple weeks and this is miserable. Or you can have people who are like, it's been 7 years
Yeah.
and I just really don't want surgery, but they're debilitated at this point and their quality of life has just completely diminished. So our range is really big. Is it case by case? Is that what you found? Or do you think there's kind of that balance of how long you should give conservative care before it's like at this point, surgery is the best option?
Yeah, I mean, I track my patients' outcomes really closely, and it'd almost be great if this existed more in general medicine. Like, how's your patient actually doing? Not
Hmm.
just come in and when I see my primary is amazing, but you go see them and they just check your blood pressure once, and they check your heart rate once, and that's such a small snapshot of
Snapshot.
time,
Hmm.
but we're not really truthfully tracking how people are actually doing over longer periods of time. And I think the long answer to your question is yeah, we should be doing like healthcare should be doing that. I think it's the future is like better data, better understanding of how people are doing over longer periods of time. And then you can catch that window of like, okay, conservative isn't really working and you are losing your quality of life. Because I think a lot of patients don't realize how much they've lost until they've
Hmm.
really hit the rock bottom. Like they go to the beach and then they can't even go on the beach. It's just like that's a big change. It's not old age. Like most people like, oh, I'm just getting old. Well, that's not the case for most people. Like you should, if you're healthy, you should be able to do what you want to do. And so you see both sides of that, the acute and the chronic. And I think tracking outcomes and progress is not done very well, but I started doing that a long time ago, even before it got popular. And I was trying to see not only how people were really doing before surgery, but how they did after I did something, and try to learn from that. And that's part of what I like to do in terms of getting people through surgery. But I think that could be expanded to better understanding how they're doing even longer term. And I was a huge advocate of tracking these outcomes like 2 to 5 years post surgery.
Mm.
And the reason for that is because them to come back if they were starting to fail again, and maybe we don't do another surgery, but we start intervening and trying to
Mhm.
improve that quality of life that's so important. And there's such limited time here, really. So, having poor quality for a long period of time doesn't make sense to me.
I think it's a relief for a lot of patients to hear, though, that there is a conservative track and not every pain leads to surgery, right? I think that's because I think so many patients, when you have the initial pain or you're in that kind of extreme pain levels, their first thought is first, oh my gosh, I'm going to have to get surgery. And then two, what is my life going to look like after surgery,
Yeah.
right? And I think the industry is catching up to where we have better options for patients now that 20 in approaches, technologies, what we have to offer them,
Hmm.
we didn't have 20 years ago, right?
Right.
And so I think that is, one of the education pieces that we try and talk about is that there are better alternatives out there now, right? And maybe that is an implant, maybe that is conservative care, maybe that's a non-instrumented procedure, right? There's a lot of options within there, but I think that's a relief for patients to hear that it doesn't have to be surgery. There is conservative care, and then I can still go through the pathway and find an option that fits best for me versus being in this one size fits all. Because I think the scary part is that chronic regression, right? Which is what you said is you don't realize how much you lose. If it happens over the course of 5 years, you think, well, this is kind of normal. Well, it's normal to what you did 6 months ago and 6 months before that. But if you look at 5 years ago and you hear kind of about the stories and all the things that they gave up, that's really tough. Where if that happens over a week, it's really easy to see. When it
Mhm.
happens over 5 years, I think it's tough.
Yeah, it's really impossible, I think, to
Mhm.
see because you live in the moment. And you know, even good surgeries that help patients. Sometimes they don't remember because they're like they're hurting
Remember.
again.
Yeah.
Like
Yeah.
they had a fusion 10 years ago, and they're hurting again, and it's like now they come in and they're like, I've had back pain for 20 years, and you really sit down and talk to them, and no, they did well for 10 years in between, and then they've had something else pop up, and it's the mind is an incredibly complicated thing, does weird stuff, makes us remember certain things and forget other things, and I think that's good and bad. But yeah, it's a complicated problem for sure, and I do hope that the patients that see me can see that's part of what I think about all the time, like how to get them through the short term if we don't do surgery, how to get them through the long term if we do.
You talk about some of these metrics and especially tracking long-term
Hmm.
outcomes. I think one of the things you're very active on LinkedIn, and one of the things that we see is I don't know if we're always looking at the right success metric for outcomes of surgery, right? I think we see a lot of images. We don't know at what time points they are. We don't really know how the patient is doing. The hardware might look good. What are the things we should be measuring? What are the things we should be looking at? Because I think some of those, and I think we're getting into it, is functional outcome metrics, right?
Hmm.
Is what you're actually able to get back to do when you're looking at, your disability and your quality of life versus, a metric on a screen, which is, I think, helpful in a lot of situations. But what's the holistic picture that we should be looking at?
Yeah, I mean, I just, functional capacity, what they're doing, are they enjoying their life, or does thing that we're the thing that we're either thinking about treating or the thing that we have treated, is that actually improving? That is actually what your patients really want to know. What you do, does it actually improve their quality of life, and does it stay sustainably better? And that's not shown in a snapshot like you're talking about. Like I am sometimes guilty of it too. I do something new and I'm excited about it. It's like this shiny new like trinket that I just thought up, or some new thing that I'm trying to do, or when I switched over to prone lateral, which was a big deal for me. Just that whole concept. Like early on, I'm like, yes, I'm very excited about this stuff. But like with most things, when I do something new, um, I always will try it for a little while and I step back and I wait before it becomes like the whole thing that I do in my practice and it's just accepted blindly. I like to see how the patients are doing. So when I switch a cage or I switch a technique, I'll do it for a while and then I pause and I want to follow those outcomes. I want to see how they do. And so while I might post one picture, I'm actually tracking like how the first 10 people are really doing with a new process or a new idea before it's a standard thing in my practice, because I want to make sure I'm not seeing complications that I didn't see, or you're sort of blinded. You can get blinded by this kind of new toy bias. So like a brand new car, you might be blinded by the fact that it's not, the gas mileage is terrible or something just because it's shiny new and has some new bells and whistles on it. That's not what surgery should really be for patients.
You're a huge pioneer and a huge advocate for MIS and motion preserving surgeries. Is that something that you brought into your arsenal because of the mentorship that you had, or is it because of outcomes that you saw in the work that you did, or maybe a combination of both?
Yeah, I think it's both. So I trained with, at Sims Murphy, there's 30 plus surgeons there. You get a very wide, very diverse training working with 30 surgeons. That's a lot of people.
Mhm.
It's a lot of people to learn, again, what to do and what not to do. And then I think it's you become this combination. If you've done it, what I think is right, it's like this person did this really well, but this is terrible. And like, but this person did that component really well. So you could take like the best parts of these mentors and really put them in one place. And Sims Murphy was unique in that way because there were so many attendings. And so yeah, I think a lot of motion preservation ideas came from that. A lot of MIS came from that. And then I got to round. I mean, the attendings didn't round on anybody, so I got to round on all these people's post-ops, and you can very quickly see like the MIS people are in a whole different world, and the arthroplasty people are in an entirely different world.
Mm.
And if you go to some clinic, which we didn't have a ton of clinic in residency, but if you went to clinic with Foley, you could tell like, wait, these people are doing very different than the other clinics that I go to. And it's just, arthroplasty patients, you you don't have to follow them very long because they'll call you back if they need something, but they almost never call you back. You follow their metrics over time, but you don't actually have to see them. It's kind of crazy. And you do the same thing. You do a minimally invasive fusion, one level or 10, and the reality is those patients end up doing really well. They're not in the hospital very long. They don't, have a lot of complications. There's always risk, but you're not managing these kind of chronic complications of open surgery. And yeah, so it's about getting that short-term outcome good. And then the puzzle piece, of course, is still that long-term outcome. Are they going to be successful long-term? How do these disc replacements hold up over decades? And I'm still learning that. I mean, that's something we're all learning. There's been a lot of discs on the market that are no longer on the market, and I've probably used every single one of them. So and there's pros and cons to each of them. And I think as I'm looking forward, always am still looking back at how those patients are doing and the complications that I've managed in the long term, in addition to the short term.
When we started this whole journey with the podcast, it was around motion preservation and preserving function and trying to get patients back to that quality of life as high as you can possibly get it. You're a surgeon that does both, right? So you do ACDF, a cervical fusion, you
Mhm.
do disc replacements. A lot of the patients that are coming in are often looking at those two options. How do you go about deciding those two when you're seeing a patient, whether you're going a CDA route and getting an arthroplasty or going with a fusion?
My mentality has definitely shifted on that quite a bit over the course of from training to actual now. And I used to do a lot more ACDFs. Now I try to find reasons not to do an arthroplasty. It's the exact opposite. So somebody comes in, they've got, the same pathology. It's like, what are reasons not to do a disc replacement? It's the exact opposite, and it's because the patients, frankly, in my practice, they do better. And if you look at a really good data, and those, everyone's going to say it's white paper or industry supported. I mean, yes, that's true. But if you look at the data on the best available data that we have, randomized controlled trials that compared actually to controlled fusion patients, I mean, that's pretty good data, is that they do better. And some of the discs actually not only do better in terms of neck pain and arm pain, but they also do better in terms of reoperation and a whole bunch of other metrics. And so it's a hard argument for me to have as a surgeon to do a fusion now if there's any reason to do a disc replacement. So it's definitely very different than when I finished, and it's been something I've incorporated. But I think for a decade, I've been doing at least over 100 disc replacements a year, and it's a big part of my practice. I'd like to do more. I'd like to do more lumbar arthroplasty, but it's a challenge. There's insurance issues and problems that have plagued that portion of our industry for a long time. But I'm also equally excited about the new stuff that's coming down the pipe. I'm excited about continuing to look at these technologies, building them into my practice, seeing where they fit, and then I hope that in the long term we have options to address like deformity and other complex problems without screws.
There are other barriers to getting these procedures done, right? Part of it is training and like having an access surgeon. That is one of them. But I think patients don't always get to see the other side of it, which is reimbursement can drive a lot of these treatment decisions as well. This is something you talk about a lot. I would love to have you kind of approach this topic and, from a 30,000-foot view, and we can dive in wherever we want. But I would really like to talk about that topic, especially with patients, on what all drives those care decisions and the technologies that can or are used.
I try it, I think, every time to talk with patients about like if they come in and they're a lumbar disc candidate, but I look at it, I'm like, yeah, your insurance doesn't cover this at all. That's one of the biggest barriers, insurance coverage, right? Some insurances are still calling experimental after 20 years. It's crazy, more than 20 years. And, I'm on the original ID study technically, I'm putting in Foley's original lumbar discs. And, that's kind of crazy to think about. And it's still experimental. I mean, this is nuts, right? But it is what it is. But, I actually send patients, sometimes I'll talk to them about tourism, there are places that are doing this and doing it right and doing it better. And, our European colleagues are well known to take patients from here. I don't love sending people away to get care, but if that's the best care for them, I have that conversation. And it's not within everyone's means to do that. I understand that as well. And it'd certainly be better if insurance covered things here. But it can be a challenge, like that insurance piece and the coverage options and checking all the check boxes. And even if they have insurance coverage, it's like 30,000 hoops to jump through to get to a disc replacement. And some patients just give up. And it's difficult to watch, but I like talking them through that. If they do have coverage, just tell them like, look, we got to do this for 6 months. Just follow the program, go to the PT, document everything. We keep seeing you. I know you wanted surgery tomorrow and you're a good candidate for surgery tomorrow, but we got 6 months together. And it's a good time to get to know the patient too. Like, how difficult are they really going to be? How many phone calls is this going to be? It's an interesting time period, but it shouldn't really be that difficult, really, truthfully. And then, reimbursement. Yeah, I get paid less to do disc replacement. And does that matter? No, I don't think that it does. And I encourage young surgeons. I actually post about this a fair amount as well. Is like, and I teach it anytime I'm around a young surgeon. It's like save money, save funds, build I think one of my attendings call it a war chest, but I don't like to call it that because it's not. It's not. It sounds violent. Build a freedom chest where you can get to the point where you're comfortable, your family's well taken care of if something were to happen to you, and then you don't have to make decisions at all based on finances. How powerful is that to remove that bias? And if you're running a private practice, I get it. You have bills to pay, all this stuff. But if you're being successful in doing this right, you're likely getting paid well, even at the ridiculous rates sometimes they reimburse us at. Just you need to get more efficient. So I love teaching efficiency in the OR. I love teaching efficiency in practice styles. I love teaching efficiency and quality and billing, which is not something most residencies teach. So whenever I'm interacting with younger surgeons, I do a lot of that. In fact, I have like a long text exchange with a lot of different people because I'll give whether I should do this or not, I'm not sure. I give my information out to these people, and I like to see how they're doing long term. It's like, look, reach out. If you've got your first X that I taught you how to do coming up, just reach out. I want it to be successful. I want your case to go well. I want everything about this to go well for your patient. I don't want really any struggles. And if you have a struggle, you should definitely call. If you didn't reach out before, just call. You should vent. We should talk about it. We should go through how to get through that. And that's it's a big part of that early learning. I didn't have that, but I would have loved to have that. And so I like to give that back.
As you were talking, I was really thinking about that financial bias that we all have, right? We all get jobs, and for a reason you're trying to take care of your family, etc. But if you think, like, if you took that financial bias out of the US healthcare system, how different would care look? You know?
Yeah, no, I think it'd be entirely different. I mean, everything's driven by fee for service and, max procedures and, do 10 levels and, do high volume surgery, operate on everybody. But like we talked about earlier, I don't think that's a good strategy for our industry, for our patients. Building more personalized care makes more sense. And then thinking about things like, would I really ever want to have like a T10 to pelvis? The answer is definitely not.
Mhm.
I don't want to have that done. I want to develop other technologies so that when I need that, I can have a better surgery. I can have a surgery that I actually want to have and do well with instead of kind of our gold standard now. So I do see that as a very interesting thing. And as more people become employed, I'm employed here. But as more people have become employed, I think it's incredibly important to try to maintain your autonomy and have say over how long you have a clinic visit. So, I see patients for an hour, new patients, because I want to get to know them. I want to actually do a full exam. I don't want to scrimp on things. I want to show them their films.
Mhm.
I want to ask them about where they're from, and I want to ask them about what they want to do. What are they looking for? And you can't do that in 15 minutes. You walk in, you go, hey, you need a fusion. My PA said so. And I feel like, at one point in my career, that was probably a thing. I used to see like 80 people a day. And, I learned very quickly I couldn't remember even people's names. And I was like, that was a different challenge. That was like learning how to max and to be very efficient. But at some point it's just like, that's not what I'm in this for. And that's not what the patients are really coming to see me for.
You talk about, I think it's such an important point as you talk about not aligning incentives, but aligning goals on the patient side. Because I think, you know, part of we're talking about successful surgery is getting back to those things that you would like to get back to, right? And can you talk about the importance of that? Obviously, it's really important on the provider side, but for the patient side, I think to be vocal about that, right? And to say, here is what I expect out of surgery. Here's what I'd like to get back to. In expressing that, I'd be curious for you as a surgeon, is that something you like to hear of like, hey, here are the things that I'm trying to get back to? Because then you can align, you know, you can align reality and you can
Options.
align treatment options, right? And you can
Yeah.
provide things that may or may not align with what they're looking for.
Yeah. I mean, it's on my intake paperwork. I
Mhm.
literally asked the question early and it's a couple different ways because I really want to know what they're looking for. Why are you here? What are you trying to get out of surgery? And, um, sometimes that's great. You see what they like, their biggest thing is they want to get back to golfing. It's like, well, I need to make a solution that fits with that world. And I need to explain to them why not to do X, Y, or Z. I have a million options, right? Um, I can do any number of surgeries, any number of ways. The question is how do I get them back to what they want to do and try to make it realistic. And then sometimes the wish list is just, it's like Christmas time. And for my 3-year-olds, right? It's like, yeah, I can't do all that.
Yeah.
we're not doing
Yeah.
that. I mean,
I'm not
uh,
giving you your exact, like,
right. No, everything that
17-year-old
got
spine back
every
in.
page
Yeah.
that has a toy marked. We're not doing that, those silly books they send out. But, it's just, sometimes it's just not possible. And you
Yeah.
have to have that conversation too, like about what's realistic about where they are
Mhm.
in terms of their health risks, in terms of their stamina building, in terms of all the things that are necessary to really have a successful surgery. You need to sometimes reframe that success. Like, what are we really looking at here? You know, a person who, is severely debilitated and they want something that's just not going to happen. I can't do that. And you need to set expectations, deal with those anxieties, have them start thinking about that, because the earlier they start thinking about that change, the better. And I don't doom anybody. I don't say, like, somebody comes in, they can't walk. I'm like, I don't do you're never going to walk again. That's a crazy thing to say to someone, because if I knew everything about the future, then I would just buy lottery tickets for all three of us, right? I mean, that doesn't make any sense, right? At the fundamental level, I believe there's healing that can happen that I will never understand. There's technology that is being developed that that I can't even rationalize right now. I can try to dream about it, but the reality is I don't know what it's going to do, and it's probably going to do some pretty amazing stuff. We're just scratching the surface in
Mhm.
spine, and we are going to see significant improvements with technology, with all the things that are coming into our field. And I don't want to be left behind. I like the challenge, like we talked about earlier, and I want to incorporate this stuff with, care and thought and caution, but welcome it if it's making sense and it's doing the right things for the people.
Those conversations you're having with patients around what, expectation setting and realities for them, how have those conversations changed from when you first started in practice to now, and how that's opened up for patients?
Yeah, I mean, I think doing the reps is very helpful. So again, being an efficient surgeon and getting to where can do like 100 disc replacements in a year and still maintain a lot of quality. Getting to that point, and that experience gives you, some predictability. You can't predict everything, but you can. You start to get the sense like this person is going to do really well, and but I got to do this, and I got to do this, and I got to make sure they understand this. And yeah, so you don't have any of that knowledge coming out. Like, we do very little clinic in our training, and I think it's not a good thing, actually. And the least favorite thing probably for residents, go to clinic, because it's like there's nothing exciting happening here. I'm watching this guy talk to this patient, or I'm talking to a patient for this guy so that he doesn't have to talk to the patient. I mean, those are the things that are happening in like resident based clinic, but that's really not what should be happening. You should be um, sweating that side of the training just as much. It's so important. I mean, half the time you spend with these people is actually, or more, is actually in the clinic, not in the OR. The OR is a short,
Mm.
quick snap, it's done. Hospital stay might be like a minute or a couple of days for some of the things I do. I mean, but the care before and after, getting everything dialed in, and getting everything perfect, and as perfect as we can make it, and then dealing with the post care and making sure they're recovering well, and going through that recovery period, and then understanding like, hey, you haven't actually walked in like, or walked reasonably in like 5 years, right? That long term loss that we were talking about earlier, you haven't actually done that, so you're not going to magically be able to do that.
Mhm.
This is not that Willy Wonka in the chocolate factory scene where the guy like hops out of bed. Even
The
laying in that bed for
grandpa,
like
yeah.
30 years, right? Which is not believable at all, right? That doesn't look real, but most of the movie's not. But that's not really going to happen. And you need to teach them, like, if you want your quality of life back, you're gonna have to go get it.
You touched on lumbar disc replacement as a great example of kind of doing all the right things, charting, keeping track of it. For patients that are listening are going down that route, whether it's a disc replacement or any new technology that has, high denial rate, do you have, a playbook or advice you could give to those patients on here are generally the things that you need to check off if you're going to go down that path to help try and get it approved, whether that's conservative care or what types of conservative care, the length of time, those sort of things?
Yeah, I mean, number one is don't smoke. I mean, I think that's the easiest one. It's terrible. It's terrible to do that. It ruins all your opportunities in terms of anything complicated for spine. And that's pretty much across the board in the United States. Like, don't smoke. It's just not smart. Um, Number two is like, yeah, maximize your conservative care. Like, really go to PT, really put the time in. even if it's just prehab, right? It's still going to pay off. You're going to learn stuff. I don't maybe have to send you to rehab post surgery because you already know what you're supposed to be doing. And I reinforce those behaviors if that's the case. And then, yeah, we're saving some time and recovery time on the back end. Maximize that stuff and start digging into your policy if you have one. Patients a lot of times just show up and they're like, I want a disc replacement, but they haven't done that work to really like understand that they don't have any coverage with their current plan. They don't, if they do have coverage, what are the limitations? Does it work for, isthmic spondylolisthesis? It doesn't, not right now, but maybe in the future, right? But the reality is, we got to start thinking about these things. And yeah, early on, you need to be really, if you have coverage, go through your insurance list. If you don't have coverage, then, again, have that conversation with me or your surgeon about what you can do. And then I usually, those same patients, I always talk to them what the bailout is. What happens if you get to the uncle moment and you're like, I just can't keep going. My quality of life is slipping and I need to do the best available care that's covered. And sometimes you got to make that call and just do it. And so, you talk them through an ALEF as an example, or whatever, you talk them through the alternative and then again, see how that next period of time plays out. But it's again, part of that research and understanding thing is like, you need to get to know what your coverages are. And the reality is your insurance might change, um, I often sometimes recommend people switch their insurance. If you have the opportunity to do that, if they're self-insured business, and I know other policies in the state cover this care with a lot of hoops, but with hoops, then great, switch your insurance.
You've talked about, and we've talked about a lot of different technologies and how technology has grown as you've kind of gone over time. I think you have a unique position that a lot don't, is that, we're seeing more specialists, right? People that focus on primary degen and or complex deformity. You kind of do a little bit of everything because of where you're at, right? You see patients of all backgrounds and types. Do you have, whether it's a technology or an implant or an approach that you're really excited about, for patients and to use over the next 5 years, 10 years in your practice?
I mean, that's a pretty long list.
Remember, he likes a challenge.
I'm excited about a lot of stuff. I'm excited about a lot of stuff. No, I mean, I think disc replacement's always going to be exciting to me. That's fundamental. I mean, I just love how those patients do. That's the bottom line. It's not as sexy anymore because it's just like now there's like 10 devices and 2 levels, and maybe we're going to get a 3 level relatively soon. And I saw a guy yesterday that needs a 3 level, and we're gonna fight to try to get that one done and get creative. But that's all happening. I'm actually really excited about Mainstay. I don't know if you've talked to them or talked to other surgeons that are doing that, but I've been doing a fair amount of reactivates lately, and it's an interesting procedure. It allows me to oftentimes ignore a lot of the other pathology and focus on a different type of pathology and a different strategy. So it's a rehabilitation device. It's very different than a fusion. If I treated these people for back pain, maybe in the very distant past, you look at their films and it's like, oh, they got some degen scoli, we got some degenerative disc disease, some facet arthropathy, not a lot of radiculopathy, they got back pain, right? And this patient will come in and I'm like, oh, let me look at the rest of the scan. We get kind of like, this mindset of just like, look at the spine. And I think one thing that really changed me was like lateral surgery. When I started doing a lot of lateral surgery, because I did 1 lateral surgery in my training. That's not a lot. But I have, since that's actually, a huge part of what I do now. But when I started doing lateral surgery, I started having to look outside of the spine. You got to look at the psoas, you got to look at the vascular anatomy, you got to look at corridors, you got to look at the pelvis. You're like, oh, they got a deformity. And instead of being a degen surgeon, which I definitely could have been, now I'm like, oh, they got a deformity. What do I do about that? And what does my cage do for that? And now when I'm looking at films, like for this reactivate stuff, I'm looking at that going like, hey, wait a minute. They've got all these things that I used to treat all the time, but they also have muscle atrophy. And then you get this opportunity to meet with the patient. They're expecting to have like a 4 or 5 level fusion because but maybe I'm the second opinion already. The first guy said or gal said, let's do a 5 level fusion, and they're nervous. I mean, it's palpable, and I'm like, I can do a 5 level fusion for that too, but what? Tell me about your symptoms. Again, I get the benefit of having a lot of time with these people, and I can then figure out if that's a good fit for that person. And then I'm doing like a 30-minute procedure that pays almost nothing. That doesn't really matter. These people, they come back to the office and they're very happy. They're doing their rehab. I mean, it's as motion preserving as anything else. I'm excited about that. And then, going back to my fusion stuff, I mean, I still do fusions. There's still use. It's like a fatally flawed surgery. It's not perfect, but it fixes certain things. And I think when things get bad enough, it's a great tool. When things get too bad for reconstruction and too bad for motion preserving based reconstruction as it currently exists, then it's a great option to do it. But then I'm using a lot of technology for that. So using spectroscopy often, using a lot of calculations in the office, just like really trying to hone down. Okay, how do I preserve motion by doing less levels? Like maximize everything. So one of my big things is prone lateral. We talked about that a little bit earlier. I'm a huge early adopter of that. I started doing them in 2019, so just about as long as anyone else in the United States. And it's been a game changer. I can put in hyperlordotic cages in almost every patient that I see at any level that I want to, and it's kind of crazy. Um, but I can now push a 30-degree or more cage into a level just by positioning and using positioner technology, which I have disclosures for. But the reality is like, yeah, I'm excited about that. If I'm going to do a fusion, I'm going to try to do it better.
Courtney, you had brought up the sweet spot for kind of getting these surgeries. I'm curious the point that you just brought up, which is there's a place where it's too far gone, right? And you lose access to some treatment options.
Yeah.
As a patient, how do you pay attention to that? How do you follow that? And like, when is the right time to enter that? Because we're not trying to push surgery too early, right? But at the same time, there are downsides to waiting too long, right? And you can lose some options. How do you navigate that process as a patient, or how do you navigate that process on the other side as a surgeon?
Yeah, I mean, it's a fine line for sure. But again, I think better outcome tracking would be the solution. It may or may not happen in the short or long term for primaries to really be doing like NDIs, ODIs, and all these other measures that we have. Myelopathy tracking would be amazing if they did that on the primary level. But that's really not being done. It needs to be done. Maybe that's another thing if I ever get any free time. But the reality is like, then patients have to participate,
Yeah.
and they have to want their health to be better. And I think fundamentally people want their health to be better, but again, they don't see it slipping away all the time. But that's what that tracking is about, is finding that window, when to do something before it's too late and now you're sort of doomed to have the most aggressive thing done. And it's a tricky window for sure. But I think if you're a patient and you're wondering, should you have surgery now, start doing some of the tracking stuff that we do. Google it, look up neck and outcomes. Do one of these surveys on yourself, and if your survey is almost normal, you probably don't need surgery. If your survey is in the moderately disabled range, you maybe should be thinking about it, and then maybe just go get a consult and realize that you've lost more than maybe you realize, and interact with that surgeon or proceduralist early and start rehabbing early. Try to beat this with, when it's mild to moderate,
Mhm.
and don't wait until it's super severe and you really have very limited options. I think that's what a lot of patients do. And a lot of that stems from the really bad reputation spine surgery has, not created just by one person in Texas, but by the industry as a whole. Because for a long time, fusion used to mean like this massive destructive thing that we did to people. And then you just like dump a bunch of bone in there and put some hooks and long rods in there. And it was hard. I think it was hard on patients, and that's got to change. We as surgeons, we have to change that language and that mentality about this. And it's going to be hard to do. We're fighting against 70 years of kind of doing it a very challenging way, and really we should you know be thinking about this as a we really need to move the bar on our reputation, move the bar on our outcomes, really show patients that this works, because people are generally not afraid to go get a hip or knee replacement, but
Mhm.
they're very frightened of having any spine surgery, even if it's a motion preserving one.
Do you think we are shifting that right now? Do you think as a whole there is that movement towards working on reputation, working on innovation, a bigger focus on motion preservation and understanding our body as a whole and the impact that fusing even can do to your linkage system? Like where do you think we're at right now in that process?
Well, I think we're doing it right now. I mean, we're we're talking about it. You guys
Yeah.
are spreading the word. There's great technology on the way. I'm always looking ahead to the new stuff, and I think again, patients are just getting more and more savvy. We talked about this a little bit earlier, but the reality is like they're getting to where they're looking things up, and they're getting more involved, and they're getting more thoughtful questions. Like people come in, and I bring up fusion, and they're like, why can't I have this?
Mhm.
They're starting to ask for the other things. And again, I'm already ahead, maybe ahead of them in that. I'm trying to find a reason not to do a motion preserving technology, and they're coming in asking about it. And I've
Mhm.
got to try to make those two worlds meet, the realities of what our current tech does versus the realities of what the other uh, older technologies that work for this problem that they actually have do. And it's a fine balance, but
Mhm.
I do think we're there. I think we're at a point when patients are coming in asking for these things. They want these things. They don't generally want fusions. No one comes in and goes like, yes, fusion.
Can't
Nobody does
wait.
that.
Yeah.
Nobody's doing that. I mean, sometimes it's the only thing that you should do, to be fair, to fusion. But uh, at the same time, 30 years from now, we're going to look back and be like, man, why was I doing that? Because I do that now. I look back to my stuff from 10 years ago or 15 years ago. I was like, why was I doing that? That looks terrible. Like that work. I mean, the patients were doing okay, but for the time, it's all judged by time.
Yeah.
And we're gonna have some really cool stuff that comes out that answers a lot of questions. Some of the biggest barriers in our what we have is regulatory, right? It just takes so long and it's so expensive. So I hope some of that can change. And I don't want it to get so bad that we just have like a million devices that don't work. But there's got to be some middle ground, you know, with some of these trial things and some of the processes of getting things to market. And I deal with a lot of spine companies for a lot of different products and solutions. And it's definitely a hiccup and a struggle when um, you want to change the color of something and it takes 6 months. I mean, it's just insanity. So some of that has to change.
We talk about a lot of the good side of healthcare. There's a lot of bad sides too, right? And we've kind of talked about denials and reimbursement and finding its way into the care system. Is there any part of that you every single day, if you could snap your fingers and fix it, is there something that you'd fix? What would be the one thing that you'd fix?
I would love to get rid of peer-to-peers.
How often are your peer-to-peers actually with another spine surgeon?
It's more often than you think.
Okay,
I
that's
think it's very rare for me to get somebody that's not a spine surgeon these days. I don't know if that's changed, or maybe I kind of pre-filter them a little bit. My PA does a lot of the junkier ones, so like getting an MRI, I don't do those. So those are probably more conversations with the non-spine surgeons than a actual spine surgery request, right? But yeah, getting rid of those would be nice. Now, full disclosure, I did that for a little while. I did some peer-to-peer reviews, and I did that for a reason. I wanted to learn it.
Mhm.
I wanted to learn this stuff. I wanted to learn the checkbox stuff. And you can sign up and do it, and it's a consultant thing. And I did it for like 3 or 4 months. But the reality is, like, I wanted to learn like what goes on behind the scenes. Like the best way to know how to defeat an enemy is to know what
Their
they're
plan is.
what they do.
Yeah.
And it's interesting to be in that environment. And I probably approved more surgeries than anyone in the history of peer-to-peer reviews, because I was like, yeah, I'm not really doing this for all the right reasons, or maybe all the wrong reasons, I guess. But it was good to talk to surgeons, and some of the notes that I got were just absolutely atrocious, though. That's the thing. Like
Mm.
I get notes, and I'm like, are you seriously you want to do this? I mean, this is crazy. And I like you got to document better. Like I'll have like an offline discussion with a surgeon and be like, hey, this is really bad. Like this note is the worst note I've ever seen, and you got to fix this. Like I'm working for these people sort of as a consultant, so not really, but I think that they're actually probably right. This is a terrible, not that the indications were wrong, but that the documentation was so poor that you know if they had worded it this way, and I can see through the lines there. I know what they're trying to say, but the documentation's so bad. It comes to you, and you're just like, man, this person's probably posting on social about how they got denied, their
Mm.
surgery got denied again, and I'm like, yeah, your note is awful. Yeah, you need to fix this. So there's a lot to that. I mean, and it's an art, and so going and doing that was actually really helpful. Like I got to learn how those people think, but I also got to kind of see the you know structures, and I got a lot more exposure. Like, yeah, this would never have worked. Like this note never would have worked. And so some of that is sort of surgeons shooting themselves in the foot. Like you've got to like dial in your documentation. If there's a checklist of problems, then you need to make sure the checklist is checked off.
Mm.
And sometimes you miss one or two little things, but um, you know, random hoops that they install. But that's fine. That's part of the process. I'd love for some of that to go away, to be fair, but I think a lot of surgeons could fix a lot of their denials by better documentation.
I think it's such a big piece and good advice too. One of the things I resonate with that you were just talking about too was this concept when you talked about progress and you say you look back 10 years and say, how could I possibly done that? But I think that's what progress is, right? Is looking back and saying, we're not doing the same thing that we just did. And I think, as we sit here, we talk to everyone, I think success for spine probably looks like knees and hips, right? When you go and get a knee or a hip surgery, people are excited and friends and family around you are excited. When you get spine surgery, it is not the same
Yeah,
talk
I feel
track.
like
Right?
it's a ghost town.
Yeah.
You don't have the same support, but when you go and get it like general ortho, people are so excited. Oh, that's going to be so much fun. You're going to get your life back. And we've got kind of the opposite talk track in spine, right? But I do think we're changing that. And I think to your point, progress is, disc replacements for 20 years. And now you've got tops with a facet replacement. And then hopefully you've got total joint replacements, right? Which are, again, ongoing clinical studies. But that is what progress looks like, right?
Mhm.
And improving that slowly over time. I think one of the things that we love so much is I think you've got this underlying theme in what you do and the way you provide care, which is how do we do better,
Yeah.
right? And to me, agnostic to everything else, implants approaches, it is how do we do better for the patient, right? And I think that's one thing that we see over and over. One of the things that I love is you actually created Delta Docs, which is a force with Charles Xavier and Wolverine, but Dr. Asgar and Kimball. And can you talk about a little bit what that is and just like creating that, but pushing the narrative of doing better in this superhero force, right? Which is the X-Men.
Yeah, I don't
I
know.
found that so funny.
I don't know. Sometimes maybe it's just a joke. I'm not sure yet. We're working on it. It's a unpolished product, but we came together. We're very different people. Like I think John Kimball and I. So I got to qualify because it's John Ashgar,
Yeah,
and
and
John Kimball. But Kimball was, I sort of met him through social, and I met John through social, and they've both been very great people to kind of bounce ideas off of. And we don't always agree. That's what's great about it. Like we don't agree. We don't agree about our strategy entirely. We don't agree about these things. We got to come to a consensus, about like what we're putting out there to some degree. And what we just want to change healthcare. We want to change some of the variables that are out there. We want to take away some frustrations that are in private world versus employed world. I've been in both areas, and so yeah, there's struggles in both areas, and we gotta we got to get some of our autonomy back. We've got to get some of our voice back. We got to be able to not have insurance companies just deny everything that's sane and reasonable care and a very appropriate care and not have to fight so much. And, I think that's what that group is really about at the fundamental level. I hope that, we've had a lot of people join. I think a lot of people don't like to post about it though, because it goes up against big organizations and they're, if you're employed, that's your
Mhm.
employer. You gotta be a little careful with that stuff to be fair to everyone that joins. Uh, but at the same time, at the fundamental level, you have to understand, like, if we're going to change healthcare, it's probably going to take more than a group of boardroom people to do it. It's going to take doctors re, re, retaking ownership of what is our profession. Like, just, one of the things I don't like is like we've been sort of lumped into provider world, which I'm okay, it's fine. I'm a healthcare provider, but at the same time, I'm a physician. And not to poo poo on PAs or MPs, we went to this. This is our calling. And for a lot of us, this means the world to what we do. And not all of us went in here to make money. If I wanted to make money, I would have done something else, right? Buy stock or run a company or put in the same number of hours in almost any other job, and you'd probably be successful, right? But this is what I love doing. And we got to get that back. Like a lot of people, I think there's more burnout. I've been burned out in my career at some point. In the middle of it, you don't see it, you don't know it. It's that same thing about your quality of life slipping away from you. And, we got to get to where that is, we do what we love and we don't have all the headache stuff. Get away from some of the clicking that we have to do every day and just start taking care of patients and doing the right thing again. And I really and truthfully believe fundamentally that the only way we get back to that is doctors taking ownership of that. No one's going to give that to us. They like us to check boxes and fill out forms. Yeah, I say they, it's like everyone,
Mhm.
politicians and insurance companies and huge healthcare systems love it when we code stuff and numberize everything. These patients are not numbers. I'm one on one with a person. Maybe that's the max number there, but it's not like CPT codes and all this other stuff, which I know really well. You have to know how to play the game, but at the same time, that shouldn't be the driving impetus of medicine is running numbers. And that just doesn't make any sense to me. It never will. And that the long answer is, yeah, we got to get back to doctors really owning our profession.
You even go beyond that in advocating. Obviously, you advocate for patients and you're advocating for yourself as a surgeon and other surgeons and physicians, but you advocate for everybody in the room. You're very notorious for posting about red hat Fridays, and I've seen Rep Park, but I've been wearing a red hat for 10 years now. And it's amazing kind of the different elements of what is acceptable, what's not acceptable, and what gets scrutinized, right? But you advocate very heavily for the importance of the whole team in the room, right? And that is PAs and that's NPs and that's your first assists and your scrub techs. That's everybody. And it's your clinical specialists and your reps. Can you talk about that? Because I think a lot of times, even for patients, when you're going into a room, you just think about the surgeon that's operating on you. And really, it's a group of 10
Mhm.
people. And we talk about this a lot. And Dr. Sekhan talks about this a lot too, of just you couldn't do it without that, right? And the importance of that team and that environment in that space.
Yeah, I mean, you can have the world's best surgeon operating and doing amazing work themselves, but if their help is not good, that's not going to be an amazing outcome most of the time, because it's so much more than just moving your hands and being very careful and being very thoughtful while you're working. It's all the other stuff. It's all the support structures, all the things that you don't even know are happening. You don't even realize are happening sometimes that people do. Safety things, things that are so important, like put the strap on the patient, make sure they're like not going to fall off the bed. Kind of important,
Mm.
right? And then, even farther than that is like, again, the med device world and what you all do uh, for us and for our patients. It's huge. There's no one that really cares as much as I do probably about that case going well, have the patient having a good short-term outcome, the day going well, and the patient having a long-term outcome. than me or the med device person. Even sometimes if it's a competitor's product to bring, you know, you want those cases to go well. In spine, we do lots of revision. You know, the it's one of the best supported things. Like if I need random screwdrivers to take out some random thing, the you guys support this service so well. Like I get those things 100% of the time. The team I have here is amazing. Like I think I'm doing better surgery here than I was when I was in Portland because the people that surround me. I'm the same surgeon. I'm a little bit less grumpy for some reason, but because things are going well. But you know, the reality is, you know, they're just taking care of the patients better. And then I have a lot of the same reps, so they followed me. This is crazy. My reps like follow me around, uh, but you know, but they care about the patients too, and they take feedback, and I give back. I'm tough on reps, to be honest with you. Social. I'm a huge fan of supporting you all, what you all do. But I'm sometimes hard in the room. I can be hard. I'll be honest. But it's a fundamental thing. I want the patient to do well. I want us to learn from whatever's not working, and I want to do better next time. And I think that rep does too at the fundamental level. They don't want to struggle again.
Mhm.
And so I'm a big fan of get rid of the red hats. That doesn't make any sense. Get rid of these blue paper garbage scrubs that are, you know, trash. Um, get rid of all these, you know, badges and things. I mean, you know, some vetting is probably good, and HIPAA training and all that stuff's probably smart, right? I mean, I think there's fundamental things we can all agree on, but having like 10 systems to do that, it's just getting out of hand. And so I'm working very aggressively on that. So I hope that you guys will palpably see the changes I'm making in that. It's a very secret way that I'm doing it, so I'm not going to say, but
Stay tuned.
it is actively ongoing, and I think I've found a solution. So I'm excited.
That's really exciting. I think just advocating, you know, for the whole room and what everybody brings to the table. Because to your point, it is a puzzle, and everybody's got a piece in that, right? And
Yeah.
that's what contributes to those good outcomes. And it is appreciated and noted. I think that's you get so much traction, and people follow so much of what you do because you fight for some of those things. And I think it's extremely important. You know, as we've taken up so much of your time, as we wrap up here, we look at a lot of what you do and what you advocate for and the education that you promote. You're a neurosurgeon, you got 3 kids at home, you are busy, you know, you are busy as it comes. And even if you checked out at the end of your surgery day and went home, you would be extremely busy. The question I have is why fight the fight that you do on LinkedIn and pushing all this information? Because that is extra work, right? It's not only extra work, but it's also, you know, it's arguments that don't have to be had and things like
Being
that,
in the
right?
line of fire.
It is.
Yeah.
And
Yeah.
it's putting your name and your voice out there. But for you, why do you go through all that? Why does it matter?
Well, I mean, I think it's with most things. I like a good challenge. I like a good fight. Not physical one necessarily. I'm not running a
Avoid
fight
those.
club. You know, we don't talk about fight club. But the reality is, no, I like a good struggle. I don't mind speaking my mind at meetings. I don't mind speaking my mind. I don't mind, you know, being controversial. I want us to be challenging the way we're thinking. It's what our patients deserve. If you're not challenging what you've been taught for the last 10 years in training or however long it is now, you know, if you're not really challenging what you've been taught, then you're probably not doing it right, in my opinion. I mean, you've been taught some amazing things. The question is, how do you get it? How do you hone it right? How do you get it to working for your patients? None of that happens by staying stagnant. And none of the improvements that our patients deserve moving forward are going to come from that line of thinking. So yeah, being out there, yeah, it takes time. And yes, I make some people angry. Not everybody's a friend. It's okay. You know, they don't have an unlike button on LinkedIn, so I'm good. You know, the reality is it's okay. You know, I'm not here to make all people happy. I'm trying to move the bar on what I do and what patients deserve, and it's a lot of work. And if I just stayed silent completely, that's fine. That'd be fine, but it wouldn't be as challenging. So And I don't think I'd have as big an impact. And I want to have a bigger impact than just my OR, my community. I've done. I've probably taught 500 plus surgeons how to do stuff over the decades, and with Scott Hodges as a mentor. But really, fundamentally, I want to change our field, and I don't want to finish this whole cycle that I'm on. Just having done spine surgery for you know just one room one time. I want to make a bigger impact across really the spine universe, and that's hopefully what the world will see when I'm all finished.
I think it's the best way to wrap up as you look at LinkedIn and your thesis and your philosophy. There was two posts that I saw that really stood out to me. You had one, it was actually after the death of Val Kilmer, to go back to the movie sphere, but you wrote about him kind of giving everything that he does as you do as well. And he said, to those in spine and those entering, there's more to life than the art of spine surgery. It is the people you care for and the people in your lives that should matter most. To quote Mark Twain, the best way to cheer yourself up is to try to cheer somebody else up. And then you followed that up by saying, we are so small, but we can make a big impact that can change a life, make your life matter. And I think those two posts to me signify who you are as a person and who you are as a surgeon, and is saying the fight that I'm fighting is worth fighting, right? And I think everybody aspires to have that, right? And aspires to have that fight, whether it's in medicine or something completely unrelated. I think you want to put your time and your energy towards making an impact and fighting a fight that matters.
Yeah, no, I think that's pretty much the sum. I mean, that's why I posted it. But no, the reality is, no, I actually truthfully believe that. I mean, I'm here. I've got a finite amount of time. I'm trying to teach my boys how to do the right thing, and I want them to do something similar. Maybe not in medicine, but like you said, in anything, whatever they do, find happiness and try to give some happiness back to the world. There's just so much not unhappiness here, and so much struggle, and so many things that we do blindly. But why? You got to question stuff, and that's again fundamentally who I am, and I like a good challenge. So yeah, I don't mind doing it. It's actually fun, and it gets me involved, and people like you want to know what I have to say. I would not have met you if
Yeah.
if I wasn't vocal. I could have stayed quiet in my
Mhm.
corner and done the work, but yeah, I want to make a bigger impact, and it's been part of who I've been the whole time. And I'm just glad that I'm able to share time with you and share that thought process, and maybe someone else adopts it. I'd love that. I'd love for more people to find passion in this, and again, fight the burnout with bringing some excitement back into what we do, not just a new widget. Widgets are fun, but um, find some things that really make this your dream job again, if it's not your dream job anymore.
I think you're certainly making the impact that you're intending to. I mean, you have these posts that have hundreds of likes and reactions to them and 60 to 100 comments. I mean, those are the debates that we're looking for, right? And those are the support. I mean, you have so many people, you look at those threads and people saying, this is what I was like doubling down on what you're saying, right? And so I think you have a ton of support for what you're doing too, and that's the reason people follow you. And we're just very grateful to get to know surgeons like yourself and
It's
work with surgeons like yourself.
the other way around. It's been a great experience. I love to see where you guys go with this, and love to see what comes out of the next phase of motion preservation. I'm going to keep a very close eye on it. Obviously, I wish we'd been part of the trial, but it kind of fell out of the time frame. But yeah, I was excited to see what comes with next phases. Like I look at everything. I'll be critical, so be
Mhm.
careful what you ask for.
That's good. Gotta stay
But
challenged, right?
I want to see what it does. I want to see what it inspires, because it opens. Even if it is just Gen 1, there's going to be a Gen 2, right? We're not going to rest on the device, one device for 20 years. No, that's not what we want to do. We want to actually take that, learn from it, and make it work for more applications and work better, and then tear that all down and do it all over again. And that's how we get better. And then that's how 100 years from now, a pedicle screw is going to look like a torture device, and that's not a bad thing. it's going to be a good thing. And we need to get there, and we're not going to get there just putting in screws.
Yep, absolutely. Well, we appreciate it. I mean, this has been incredible. We appreciate you taking the time. Obviously, as we've talked about, for the patients that are looking for you, you have so much educational content on LinkedIn. We're here at Prosser Memorial. What's the best way if a patient's looking for you? What's the best way to find you or get in contact with you?
Reach out through your primary care, get a referral, or you can call the clinic, and we have a self referral process as well. Some insurances don't allow that, but when it does allow, we work with you on that. And then just reach out. It's actually easier than you think. There's a good chance I'll talk you out of surgery, just to be fair. But if you end up needing it, I'll be happy to take care of you. So
We'll put all your information in the caption of the episode so they can find you.
great. Thank you.
Awesome. Thank you, Dr. Yam.
Yeah. Thanks for your
Dr.
time.
Yam.